topographic anatomy means only that I'm going to locate surface landmarks that will provide me with some indication about the course and location of deeper anatomical structures. And the first area I'm going to deal with is the glabella. It's called a dangerous zone. It's considered one of that. And here we normally inject either toxin and fillers. And you have to know that every time that we contract a muscle over a fixed structure like a vessel or a nerve, we develop a line or a crease or a wrinkle. And she cannot frown now because she had a little bit of botulinum toxin in December, but it doesn't matter because her furrows and her wrinkles on the glabella are very well seen and very well located when I push. So the first crease that I see, the most middle one, that one is indicative of the last branch of the ophthalmic artery. The supratrochlear artery will come from here, and then it will go up and arborize all around the forehead, like this. Then I will go and I will look for the supraorbital crease. And in her case, if you cannot see it, especially in Asia because they don't have any wrinkles, I'm so jealous of them, you can palpate the orbital rim and look for a supraorbital notch. And once you find it, you will see that this crease is responsible because it marks the way of the supraorbital artery, and again some arborization at the end. So once you do this and you have most of the arterial vasculature of the forehead, I will go to the face. And in the face, where is the facial artery? So I know where it starts. That means that it starts from the external carotid artery and it go over the border of the mandible exactly in front of the masseter muscle, 0.5 centimeters. So ask the patient to bite, if you can bite, thank you. And if you palpate, you will feel the pulse. And now I know that this is the beginning of the facial artery. Then I don't know exactly the course of it and the path, but I know where it ends. And it will end here in the piriform fossa. Now we do have some variations, as Dr. Castemon said, and we know this because of studies done in South Korea by Dr. Kim and Dr. Moon. And the artery could be either medial to the nasolabial fold, on the nasolabial fold, lateral or more lateral. In Asian patients, the probability of any of these is around the same, 25%. But in Caucasian patients, we're almost sure it's more lateral than medial in most of the cases. And you can help yourself again with some digital compression to know exactly where is the artery. So in this case, the artery will end here. Now, the trajectory of it is very irregular. It's serpentine and sinuous. It goes more or less, will go like this because it has to give some laxity for movement. And on their way, this facial artery will give some branches, the inferior labial and the superior labial, like that. Now, let's go back to the piriform fossa. Can we see there? Okay. So right there, the artery is going to change directions. It will go upward. And since it's going to make an acute angle here, then it's not longer called the arterial facial artery. The facial artery is called the angular artery. And it will go up exactly on the border of two anatomy units, the nose and the mid-cheek. So it will start going up here, and after that, it will give its first branch. Very important if you're going to do the noses, because this is the lateral nasal branch, And I know where it is because it always is on that. I can push, and see that the artery will be in the alar groove. It will continue to the tip of the nose. It will give a little artery here on the mid-alar crease, but it will continue like that. And where are we going? Artery. Again, we have several variations, but it might finish in a dead end. But in most of the cases, in most of them, we see that the angular artery comes up, and then, like Dr. Castemón said, there is a branch of the supratrochlear called the dorsal nasal artery. And this artery goes down and anastomosis with the angular. And there we go. Here we are with the area that is responsible for connecting the external carotid system with the internal and responsible for most of the distal and more freaking complications, which is blindness and cerebellar ischemia. But other than that, we can now continue with the venous system. Remember that, if we can zoom out, okay. Normally, the venous and arteries will go together. Facial vein, that does not happen because it will have a more posterior and lateral trajectory, and then it will continue caudal. Down, we can, okay, straight toward the carotid vein. Up here, you will normally see a branch of the vein, which is an intercanthal, and this is what normally bruises during putting some fillers on the bridge of the nose. So that's the vein, and that's the artery systems, and this is the first level of knowledge that you need. And now I'm going to go to the temporal area, and to locate the continuance of the external carotid, it's very easy to push the tissue towards the auricle, and you will have a crease. And this crease is where, if we go like this, there you see the crease, and this crease will delimits and marks the emergence of the superior temporal artery. Then it will cross not more than 1 centimeter in front of the auricle, and it will go on top of the zygoma bone, and will start going medially about 1, 2, 3, 4 centimeters above the zygoma. It will continue like this. It will make the frontal branch, and then the parietal branch. And this will be the superior temporal artery and its branches. And yes, of course, there are some cases that these branches connect with the supraorbital branches, and we might have another source of continuance between the external carotid and the internal carotid. Having said this, this is just the first level of security. You have to know the position, the location of your vessels. But the second level that we have, thankfully, is depthness. We need to know how deep these vessels are so we can avoid them. So, to start again in the glabella, the emergence of the supratrochlear is deep from the bone. It continues under the gallia, that means the undersurface of the muscles, both the corrugator and the frontal, and 1.5 centimeters above its emergence, around here, it will perforate the frontal muscle, and it will continue superficial to it. So here we have then deep in most of the cases, and superficial after that. Contrary to this, most of the trajectory of the facial artery is deep, like Dr. Castemón has said. It goes under the muscles. And in the temporal area, it goes under the superficial fascia. So most of it is superficial. So to recoup, here we have deep. Here in the temporal, we have superficial. And here in the glabella and forehead, we have a mixed. Theoretically, it's safe to go strictly with the cannula under the dermis to put some filler. Here, it will have to be deep over supraperiosteum. Here, we have options, either with a cannula to be in the subcutaneous fat, better ways also to do on the superficial fat temporal compartment. And most of us, if you can zoom out exactly, most of us put it inside the muscle because it's an avascular plane around this area.